It's time for another Puscast covering the first 2 weeks of February. Got to stick that R in there. 2013. Blah blah blah, blah blah blah. Let's move on to the literature, shall we? So I always start at the phylogenetic, smallest part of the microbiologic world, and that is usually a virus. And how's about flu? I've talked about some mathematical modeling that suggested that one of the ways to stop the spread of influenza in a community is to close the schools. There was a natural experiment in Texas. Well, there have been a lot of those in Texas. But they had the flu outbreak, and so one community shut down all their schools, and the rest did not. The schools were closed for 8 days. What happened is that the number of cases of flu-like illnesses and emergency room visits for influenza fell in the community that shut their schools down. And it fell by about 27%, which is pretty good. So I'm sure not only were kids not spreading it amongst themselves, but they weren't bringing it home and giving it to their parents, who then took it to work, and blah, 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 blah. Transmission of illness was markedly decreased by shutting down the schools. If you're a connoisseur of bias, you probably have been reading the Cochrane reviews over the years on influenza, and the current brouhaha between the Cochrane reviews wanting all the data from the company that makes oseltamivir, and evidently the company is not releasing all their data. And so the Cochrane reviews, amongst others, has cast doubt upon the efficacy of oseltamivir in the treatment of influenza. There are more, of course, than randomized clinical controlled trials that show benefit, although that is the gold standard. This was a meta-analysis published in the Journal of Infectious Diseases that looked at the benefits of oseltamivir in hospitalized patients. And they found that early therapy, less than 48 hours after the onset of symptoms, reduced the likelihood of ICU admission or death by between 50 and 65%. And this was based on 90 observational studies with 35,000 patients, which I find to be fairly compelling, and one of many studies to show the benefits in certain populations of treating influenza with a neuraminidase inhibitor. I'm sure you remember SARS from a couple of years back. There's another new coronavirus. This one has been found primarily in Saudi Arabia, and now there's been some person-to-person transmission in Great Britain. Only about a half a dozen cases to date, so nothing to cause a panic over. I'm more worried about asteroids hitting the Earth right now than this particular SARS virus, but one never knows. There is no legitimate reason why vitamin C should be of benefit in the colds and flus, except that a double Nobel Prize winner decided, I've been good in chemistry and good in peace, now I will be incompetent in medicine. That is the Peter Principle. People rise to their level of incompetence and stay there, and if they master a field, they then become incompetent in another. Go Dr. Pauling. But there is no good prior plausibility to suggest that vitamin C should do diddly. The Cochrane reviews piled together all the trials on vitamin C in the cold and found that it did not prevent cold in a general population. Quelle surprise. It may have been helpful in people who are involved with extreme activities like skiing and soldiering in the cold and that sort of stuff. And as far as decrease in duration of symptoms, the pooled data suggested about an 8% reduction in symptoms in adults, 14% reduction in children, which correlates to a couple of hours, which probably is just all bias in the study. There's no reason for vitamin C to work, and it doesn't, at least in normal people. Of course, the Cochrane reviews, as always, even when it's something stupid, like acupuncture in mumps, says that more studies need to be done. No, we don't have any reason to suspect that vitamin C is going to do diddly. We don't need further studies. That money could be better spent on vaccinations or ID doctor salaries. I don't know if you guys do alcohol locks in your patients, but what you do is put 70% alcohol into the CVP, let it dwell for a while, and then withdraw it or push it through. that's been shown in some studies to decrease infection rates. This study showed a dramatic decrease in infections in patients who were on TPN and had chronic lines. They went from 7.29 per 1,000 line days in the placebo-ish group to 1.16 in the ethanol therapy group, which is pretty impressive. New line replacements, however, were similar in both groups. Unfortunately, not all lines are amenable to alcohol lock since it can withdraw the plasticizer in the plastic, but it is a good thing for preventing infections in patients with long-term catheters. My goal, of course, is to see if PO Hefeweizen will be as effective. And I also wonder if Hefeweizen would be good as a surrogate for probiotics. But that's a trial that has yet to be funded. For those of you who have the misfortune of living in the American Northeast instead of the beautiful Pacific Northwest, there's a new flavivirus in the Lyme areas. It's spread by the same tick, and it's called the deer tick encephalitis. Just to warn you that it's out there. There was a report about it in the recent Clinical Infectious Diseases. There's probably a lot more flaviviruses out there than we're aware of. One of my favorite psychological aspects of human beings is the Dunning-Kruger effect, where the person who knows the least about a topic is the most sure that they are expert and are least able to recognize that they don't know a burrow from a burrow, an ass from a hole in the ground. This also concerns, I often think, the treatment of infectious diseases, where I'm always boggled at how people don't recognize the significance of what they are seeing and then treat the infection poorly. In the last 4 weeks, I've seen 2 patients sent out the door on oral therapy, Keflex in one case and clindamycin for another, for Staph aureus bacteremia. And what a surprise, they were all handled by surgery residents. Who'd think that a surgery resident would overestimate their knowledge base? Certainly not me. There have been multiple studies that demonstrate that an infectious disease consultation is of benefit in patients with Staph aureus bacteremia, showing decreased morbidity and mortality and subsequent cost. This study looked at the outcome in patients who had a phone consult for their Staph bacteremia as opposed to the real deal, and found that 90-day mortality was increased for phone consultations compared to a bedside consultation. This may come as a surprise to some of you listening, but you don't really know what you're doing, especially with Staph aureus bacteremia, and you should probably give me a call for a consult. That being said, at my institutions, we have such good hospitalists that they can usually manage a Staph bacteremia almost as well as I can. Don't let them know I said that. You always have to be wary of after-the-fact analyses of data, but this is still interesting. They looked at the outcomes in patients who were treated for Streptococcus pneumoniae in the trials to prove that ceftaroline is efficacious for pneumonia. Unfortunately, they still haven't done the MRSA studies we all desperately need. But interestingly, those who got ceftaroline in these 2 trials had an 85% cure rate versus 68% in those that got ceftriaxone. So getting ceftaroline was associated with a better outcome for Streptococcus pneumoniae pneumonia. Over the years, I've become decreasingly skeptical about the benefits of probiotics, in large part because the issues of the normal microbiome are becoming increasingly evident, and you can have a trade-off between the normal microbiome, a microbiome associated with disease, and a more benign synthetic microbiome, such as you might provide with probiotics. This study looked at bacterial vaginosis and the efficacy of probiotics in a double-blind randomized placebo-controlled trial. And they found that those who got probiotics, they contained Lactobacillus rhamnosus and Lactobacillus reuteri, had better institution of their normal flora compared to placebo. After long-term follow-up, the difference was 51% had normal flora in the probiotic group versus 20% in the placebo group. So this may be a way to help reconstitute vaginal microflora and perhaps other infections as well. And just because an organism is sensitive doesn't mean it is sensitive. What the hell are you talking about, Crislip? Well, this study looked at the outcomes in patients with ESBL-producing gram-negative rods and looked at outcomes versus the MIC. If your MIC to cefepime, which is resistant, was greater than 16, you had an 86% mortality rate. If it was 2 to 8, which is still within the cutoff for susceptibility, your accrued mortality rate was 68%. But if your MIC was less than or equal to 1, your accrued mortality was 30%. So this is like MRSA. It can still be in the sensitive range, he says using air quotes, but nonetheless it will have poorer outcomes than those organisms that are more sensitive. MICs matter. By the way, they have found MRSA in hamburger, and they find ESBL producing E. coli in chicken meat. And finally, just to make you nervous, the metallo-beta-lactamase, the New Delhi metallo-beta-lactamase, is now for sure in the United States. It's caused an outbreak of disease in Denver, Colorado. We are most assuredly sliding into the post-antibiotic era. I'm back from shopping and stacking wood. Did you miss me? And there's nothing more aggravating than the sound system on Macs. Getting the inputs to work and they fade out. Ugh, what a pain. But you don't care. You want to know about infectious diseases. Well, this is just a curiosity. You know, one of the things I like to harp on about is the microbiome. And this study looked at the difference between kids who were C-sectioned and not breastfed versus normal births who were breastfed. And they found a marked difference in the microbiome in the two groups of kids. The kids who weren't breastfed had higher abundances of Peptostreptococci and also had more other organisms whose family names I cannot pronounce. What the long-term significance of this is, I don't know. But we all know that having an early microbiome and its constituents may be important in helping ripen the immune system. So whether or not these kids will have more problems later because of this is an interesting research topic. Cleanliness is next to something. I can't quite remember what. Maybe chlorhexidine will help that along. This was a study in the New England Journal of Medicine where everybody got chlorhexidine baths in the ICU. And they had a dramatic decrease not only in infections, but in MRSA, VRE, line-related infections. And it varied by infection, but overall a third to a half less infections in patients that got chlorhexidine baths with no issues with dermatitis and no issues with resistance. One of the aggravating things about these sorts of studies, and we get the same problem in surgical prevention studies, is they never publish what their baseline rates are for basic infection control. So we don't know in this institution what their hand hygiene rate was in the ICU, how good they are with their skip procedures, with the bundles for ventilator-associated pneumonias, UTIs, and for the prevention of line-related infections. So when you read these articles, you don't really know if the chlorhexidine baths that they're doing is a surrogate for overall sloppy practice. And by having sloppy practice, they're getting benefit from the chlorhexidine. Or if they did everything right, all the basic infection control, then they're getting actual benefit from the chlorhexidine. As I say, I have the same problem reading the surgical literature when they do an intervention. You don't know how good they are with their skip procedure. You don't know what their hand hygiene compliance rates are. So you always have to read these particular articles with a grain of salt substitute. A bunch of quickies about mycobacterial infections. One, a study published in Thorax shows that patients who get the BCG in childhood continue to have protection from tuberculosis as they get older, so that it has an effect decades after vaccinations, although it still is not the world's greatest vaccine. There's also a suggestion that patients on inhaled steroids, that's inhaled steroids, may have an increased risk of non-tuberculosis mycobacterium infections. So inhaled steroids has been a risk for MTB, and it may be a risk for NTM, pulmonary disease, as well. The rates go up about 16-fold in patients who use inhaled steroids. The other bête noire I have, of course, is vitamin D and the effects on tuberculosis. This was a randomized placebo-controlled trial of vitamin D in patients with pulmonary TB, and patients on high doses of vitamin D accelerated their clinical course, their radiographic improvement, and had better compared to those who are vitamin D deficient. I've been seeing a lot of tuberculosis lately, and I've been making sure they're all on vitamin D. And also there's a meta-analysis in the Lancet that looked at corticosteroids for all forms of tuberculosis. They found 41 trials, including pulmonary TB, and they found that there's a suggestion towards steroids reducing mortality across the board for all forms of TB, including pulmonary disease. Although across the board it was only, and I use only in quotes, because 17% is pretty good, but only 17% decrease in mortality. As is always the case, you are required by international law and treaty at the end of any meta-analysis, no matter how stupid, again I'll mention the acupuncture and mumps one, that more research needs to be done. This time, that's true. Cutaneous leishmaniasis is a pain for those that have it, especially in third world countries where IV therapy may not be easily to give, places like Georgia and Mississippi, and Tunisia, where this study was done. They had patients with leishmania major, and they were treated with either paramycin 15% with and without 0.5% gentamicin, and found the cure rates for the combo therapy was 81%, for the paramycin alone 82%, and 58% in those who just got the placebo. So it looks like there's good benefit from topical therapy for cutaneous leishmania major in patients in Tunisia, which is certainly easier to do than IV therapies in that part of the world. Man, that's it. Only 17 minutes and 10 seconds. What's wrong with me? Probably because I'm tired. I'm on call this weekend, and I'm in the middle of a 12-day stretch covering my partner as well as my own service. So 17 minutes of me is all you get this month. Plus, February is a short month, so people just don't publish. Don't forget, as always, if you're bored, you can go to iTunes and write me glowing reviews. And visit my website, edgydoc.com, where you will find links to my growing multimedia empire. My books, my blogs, my podcasts, my iPhone apps, and my Minnesota multiphasic personality inventory, so you can just see how I really am. Otherwise, see you next time. Thank you, as always, for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation, I'm going for a walk.